Hello and welcome in this presentation of secondary pulmonary lobule. Actually, this is the second presentation on my channel. Let's start. The learning objective of this presentation is learning the anatomy and pathology of secondary pulmonary lobule, how to differentiate between different patterns of the HRCT, and how to differentiate between specific signs of HRCT like halo, atoll sign, trim, bud crazy, paving sign, interlobular septal thickening, honeycombing, mosaic attenuation, air trapping, ground glass opacity consolidation, cystic pattern, and nodular pattern. And at the end, we take home message and summary conclusion for this presentation. So, what is the secondary pulmonary lobule? The secondary pulmonary lobule is the main anatomical and functional units of the lung. It is composed between in the centers by the terminal bronchioles, and in the center also there are the terminal arterioles. These units connected to about 5 to 15 acini. The function of that is gas exchange between deoxygenated blood in the arteriole and then return the blood to the lung through these veins, pulmonary veins, which located at the septa surrounding these secondary pulmonary lobule. So we have septa. These septa have lymphatics and venous structures, and at the center there are terminal arteriole and terminal airways as well as acini. Through this anatomy, we can detect the pathology according to this anatomy. As we see, this is the normal secondary pulmonary lobule, have normal thickness in the septa, and also the central arteriole and venule and bronchi. There are no abnormality detected at the center. In the interlobular septal thickening, this interlobular septa is thickened due to venous or lymphatic problem. Sometimes there are intralobular septal thickening also. If there are thickening of the terminal bronchovascular structures, this representing pathology in these structures, not in the venous or lymphatic. And the fissures we can detect also smooth and nodular thickening if it is present through HRCT study. As we see here, there are about 5 to 15 acini. If this wall of the alveolar walls is destructed, distal to the terminal airways, it causing cystic structures in the center of the secondary pulmonary lobules, as we see here, cystis of the centrilobular emphysema. If the secondary pulmonary lobules are opacified, these opacifications can be ground glass like this or consolidation like this. And if give me a few seconds, I will differentiate between both of them in details in next slides. If there are multiple cystic structures connecting to the pleura and also have thick wall, this is called honeycombing, and this is occurring with the end stage arterial disease. And also the terminal bronchioles, if it is dilated, it is representing a bronchitis. So through these secondary pulmonary lobules, I can detect a lot of pathology according, as we will see during the next slides in these presentations at the HRCT. First of all, this is a normal HRCT, can show the fissures like this, and can show the terminal arterioles. However, the lymphatics and venous structures normally cannot be seen at the septa. If it is seen, so that this is pathology and representing interlobular septal thickening. So we have 4 main patterns of abnormalities can be detected through the HRCT. We can detect lines like this. This is called a reticular pattern, or dots like this. It is called nodular pattern, or patches like this. It is called patches, or cystic lesions like this and this and this. It is called the cystic pattern abnormality of the HRCT. We have these 4 patterns, and every pattern have subtypes. According to the subtypes, we can detect the differential diagnosis of the disease. We're starting with the first and most common pattern is the patches opacity. The subtypes of patches opacity are 4. The first one is the ground glass opacity, like this, and the second is the consolidation. We can differentiate between ground glass and the consolidations by visualization of the pulmonary vessel, as we see here. The third pattern is the mosaic attenuations. These areas of low attenuations in the lung with sharp demarcation. And we can differentiate between the ground glass and the mosaic attenuations as we consider this is the abnormality or this is the abnormality through the sharp demarcations, which going with the diagnosis of mosaic attenuation. Also, if there are presence of expiratory film air trapping like this, it representing mosaic attenuations and not ground glass. And also we can look at the vessels through the area of low attenuations and through the area of high attenuation. If the blood vessels are scanty at the area, it representing the pathological area. So if we give me a few seconds, I mention it in details in next slide. So the patch opacity, we have subtypes of patch opacity: ground glass opacity, consolidations with air bronchogram, mosaic attenuations, and air trapping. As we mentioned before, the mosaic attenuations is the low attenuation area through the lung. And this low attenuation area, as we see, have scanty of blood vessels and also have sharp demarcations from normal lung tissue. And if we compare this mosaic attenuation area by this area of abnormality of high attenuation, we saw unsharp demarcations between the area and the normal lung tissue, not like this have sharp demarcations, and also scanty blood vessels within this area compared with normal lung area. So we consider this is the abnormality, and this is mosaic attenuation in patient of chronic pulmonary embolism, and this is ground glass opacity in patient with pulmonary hemorrhage. What is the differential diagnosis of mosaic attenuations? It can be due to small airway disease or due to thromboembolic disease. How we can differentiate between both? By expiratory film. If we do expiratory film and show these areas of increase areas of low attenuations, it's called air trapping. And this occurs only with terminal airway obstruction or diseases like constrictive obstructive bronchitis, asthma, hypersensitivity pneumonitis, and so on. However, if this finding is not present, it representing thromboembolic disease like these mosaic attenuations of chronic pulmonary embolism. And this is the difference between the ground glass opacity, which can visualize the blood vessels through the opacity, compared with these consolidations, which cannot differentiate the blood vessels through the opacity, and instead we can see the air bronchogram at it. The ground glass opacity have a huge differential diagnosis. As we see in these slides, about 17 pathology only in these slides, maybe there are more. As we see here in the pneumocystic cranial pneumonia, the non-specific interstitial pneumonia, there are areas of ground glass appeared here. Sarcoidosis, there are ground glass opacity superimposed with interlobular septal thickening, which is called crazy paving, and lung fibrosis, as well as a little bit lymphadenopathy. Chronic eosinophilic pneumonia also can show ground glass opacity in subpleural distributions and consolidations. Bronchoalveolar cell carcinoma, mass-like lesions with ground glass and consolidation. Cytomegalovirus pneumonia also showing ground glass opacity. Extrinsic allergic alveolitis or hypersensitivity pneumonitis can show ground glass opacity plus centrilobular nodules also. Diffuse alveolar hemorrhage, which can occur due to diseases like Wegener's granulomatosis, can see also ground glass opacity with fluffy pattern appearance like this. Cardiogenic edema shows ground glass opacity in the lung with enlarged cardiac size, as well as Curley's line and pleural effusion. In SARS, severe acute respiratory syndrome, we can show ground glass opacity, which have sharp demarcation between the normal lung tissue and between the abnormal tissue, as we see here. The ground glass opacity also can be seen in the COVID-19 in subpleural and basal distribution. In MERS, Middle East Respiratory Syndrome, also can see ground glass opacity associated with pleural effusions and noted as peribronchosvascular distributions, as we see here. Methotrexate toxicity, if we have history, can cause ground glass opacity and interlobular septal thickening, as we see here. And syncytial respiratory syncytial virus pneumonia can show also ground glass opacity in patient receive chemotherapy after ovarian cancer. This is this cumulative interstitial pneumonia case in patient smoker showing ground glass opacity and thickened pleural interlobular septa. Pulmonary alveolar proteinosis also showing ground glass opacity superimposed with interlobular septal thickening, cryptogenic organizing pneumonia, subpleural and basal ground glass opacity and consolidations can be seen also according this study. So we have non-specific diagnosis. If you find ground glass opacity, we need to concomitant data and finding on the film to choose one from the differential diagnosis. Ground glass opacity sometimes appeared as malignant like this when it comes as a unifocal lesion. So unifocal ground glass opacity should be take care from it. This is diagnosed by biopsy as bronchoalveolar cell carcinoma. However, these unifocal are diagnosed as inflammatory process according in this study. Another way we can differentiate ground glass opacity into two groups. If the patient presented clinically unwell, this representing acute status, and the MOSAIC ground glass opacity can be considered one from this group of differential diagnosis: pulmonary hemorrhage, pulmonary edema, acute respiratory distress syndrome, or atypical pneumonia like SARS, MERS, COVID-19, PCP, CMV, respiratory syncytial virus pneumonia. If the patient is well, so the condition is considered chronic, and the differentiation is occurs between these group: cryptogenic organizing pneumonia, chronic eosinophilic pneumonia, non-specific interstitial pneumonia, usual interstitial pneumonia, pulmonary alveolar proteinosis, extrinsic allergic alveolitis, methotrexate toxicity, or sarcoidosis. It depends on the patient clinical status, concomitant data, and finding on the film. As this patient, 48 years old man, confirmed diagnosis of SARS, showing ground glass opacity with sharp demarcations between the normal and abnormal lung tissue, as we see here in the superior segment of the lower lobes and the middle lobe, lingula, and also upper lobe. Another patient of COVID-19 positive case, 45 years man, showing multifocal areas of ground glass opacity in the HRCT, seen in the upper lobe, in the middle lobe, in the superior segment of the lower lobe. There are area of consolidations, as we can not differentiate the pulmonary vessels through the opacity. And this is the coronary format and volume rendering study, which confirmed the diagnosis of this ground glass opacity and confirmed by PCR as a positive. Another patient of ground glass opacity. For patient confirmed diagnosis of MERS, we see the upper lobe subpleural distributions, ground glass opacity. Also, there are pleural effusion and thickening. There are peribronchosvascular distributions, areas of consolidations, and interlobular septal thickening can be detected also. This is another patient, 60 years old, showing in the first study multifocal ground glass opacity in the subpleural distributions, which is stable or slightly responding in the next study done after 11 days. This patient is confirmed diagnosis of COVID-19. Let's look at a few more cases. This is just X-ray showing a multifocal consolidative area in the central area. The peripheral area is spared. The CT confirmed presence of ground glass opacity with air bronchogram, non-visualization of the blood vessels through it. This area of consolidations and this area of ground glass opacity, which can differentiate the blood vessels through the lesion. There are pleural effusion also. This patient was COVID-19, also unsure or indeterminate according to CORAD-3, and in the laboratory finding they are negative. Little bit more cases, multifocal ground glass opacity in subpleural distributions in the lower lobe, in superior segment of the lower lobe, and the basal distribution with patient positive COVID-19. Now we are going to discuss the second form of the HRCT pattern of pathology in the secondary pulmonary lobule. This type is a cystic pattern. As we see in all these different patients, we have cystic abnormality through the lung, and we can detect this cystic abnormality clearly. What is the differential diagnosis according to the type of cyst? As we see here, the cysts are uniform distribution and uniform size for patient of Langerhans lymphangiomatosis. And this patient of Langerhans cystitis showing bizarre shaped cysts with nodules. This is honeycombing appearance, honeycombing rows of cysts touching to the pleural surface. This occurs with end-stage fibrosis, as usual interstitial pneumonia. However, these cysts have imperceptible wall and occurs in the center of the secondary pulmonary lobules at the center, and this is representing destruction of this alveolar wall and leading to distal to the terminal arterioles and leading to formations of these cysts in the centrilobular emphysema patient. This is another patient of centrilobular emphysema, and we can discriminate the central arterioles as the center of these cystic lesions, and the thin wall also representing and sparing of the pleural and the fissural surface. This is centrilobular emphysema patient. This is another case of honeycombing appearance for end-stage fibrosis, and this case of multiple cysts with bizarre shape and different size associated with nodules representing Langerhans cystitis, and this uniform distribution cystis in the productive age female patients representing lymphangiomatosis. So the differential diagnosis of the cystic lung lesions, it may be honeycomb in the end-stage usual interstitial pneumonia, centrilobular emphysema, as we see in the centrilobular emphysema, cystic bronchiectasis if the cyst connecting to the bronchial tree, or cystic lung disease like Langerhans cystitis if the cysts are bizarre, or lymphangiomatosis if the cysts are uniformly distributed. The third pattern of abnormality in the HRCT for the secondary pulmonary lobule is the reticular pattern. The reticular pattern is meaning lines of thickening like this, and this is representing interlobular and intralobular septal thickening, and this is the pulmonary lobule, and this is the wall which is thickened due to venous problem or lymphatic problem. As in this patient, there are lymphangitis carcinomatosis, or this patient of heart failures and ground glass opacity superimposed with the interlobular septal thickening, which are smooth and uniform in cardiogenic pulmonary edema. This interlobular septal thickening in patient with lymphangitis carcinomatosis, and this is another case of lymphangitis carcinomatosis showing interlobular septal thickening, as we see here associated with ground glass opacity and lymph nodes. This patient of pulmonary alveolar proteinosis, which is showing the crazy paving appearance of ground glass with interlobular septal thickening due to surfactant overproduction, and in this case of cardiogenic pulmonary edema showing the smooth uniform interlobular septal thickening. So, if there are interlobular septal thickening, the differential diagnosis may be the differential diagnosis lymphangitis carcinomatosis, sarcoidosis, pulmonary fibrosis, alveolar proteinosis, and edema. And this is a patient of interlobular septal thickening. As we see here, there are interlobular septal thickening, and also there are interlobular septal thickening here. And we can see the secondary pulmonary lobules. There are suspected mass here, and the diagnosis is considered the lymphangitis carcinomatosis due to this mass. The fourth pattern of the HRCT is a nodular pattern. If we see nodules like this distributed all over the lung, we consider it the nodular pattern. The nodular patterns are classified subtype classifications is centrilobular nodules within the center of the pulmonary secondary lobule, and or lobules which is distributed is peribronchosvascular or perilymphatics, as this patient of sarcoidosis associated with lymph node. And if the nodules are distributed all over the lung, touching the pleural surface and in the center also, so this is considered randomly distributed, and the Miller nodule occur with a Miller TB as this patient or Miller metastasis. This patient have central-lobular nodules, as we can see the fissure clearly, pleural surface clearly, and the nodules are distributed in the center of the secondary pulmonary lobules, and this patient was a hypersensitivity pneumonitis patient. So the differential diagnosis of nodules may be centrolobulars, perilymphatics, or Millery. Centrolobulars differential diagnosis: endobronchial TB, extrinsic allergic alveolitis or hypersensitivity pneumonitis, respiratory bronchiolitis, associated interstitial lung disease occurring with a smoker patient. Invasive mucinous adenocarcinoma also can cause centrolobular nodule. However, if the nodules are perilymphatics, the main diagnosis is sarcoidosis or lymphangitis carcinomatosis. Sometimes pneumoconiosis causes these nodules if the nodules are dense and there are history of worker, like coal miners workers or silicosis. If the nodules are randomly distributed, it considered the Miller nodules occur with the Miller TB or Miller metastasis if we have a primary to diagnose this Miller metastasis. This is 25-year-old male presented with cough and granulomatous uveitis. We see the peribronchovascular and the perilymphatic lymph nodules, and this patient diagnosed as a sarcoidosis. Let me talk about the specific HRCT signs, which can also make a differential diagnosis and can help to diagnose the pathology if one of them are present. The first one is the HCT halo sign. The CT halo signs meaning pulmonary nodule like this, surrounded by ground glass opacity, or like this, in patient with immune compromised. And this also the pictures of the halo signs, which representing sun shines and surrounding by its halo. As we mentioned, this occurs in the immune compromised patient, so invasive aspergillosis is the first on the top of the differential diagnosis. Hypervascular or hemorrhagic metastasis are also can be considered as one of the differential diagnosis of CT halo signs. Wegener's granulomatosis, Kaposi sarcoma, invasive mucinous adenocarcinoma also can be considered differential diagnosis. This patient is 60 years old with acute myeloid leukemia. Female patient showing multiple invasive halo sign, and this invasive halo sign noted at the left upper lobe and in the superior segment of the right lower lobe, and diagnosed as invasive aspergillosis as the patient have a low immunity. The second sign is the inverted halo sign or atoll sign, and inverted halo signs mean ground glass opacity with edge of the consolidations like this and like this. And this inverted or atoll halo sign, inverted halo sign or atoll signs looks like these pictures of the islands surrounded by lands like this. And the most common cause of these are cryptogenic organizing pneumonia and chronic eosinophilic pneumonia. The third most common specific signs in HRCT is a crazy paving, and the crazy paving looks like this due to ground glass opacity within the secondary pulmonary lobules associated with thick septum of the secondary pulmonary lobule, as we see here in the upper lobes bilaterally in this patient. And the differential diagnosis a lot, and the most common one is the pulmonary alveolar proteinosis. The other infection cause is the pneumocystic cranioid pneumonia. Neoplastic causes mucinous bronchoalveolar cell carcinoma. Lipoid pneumonia also can cause this. Adult respiratory distress syndrome can cause this crazy paving appearance in the HRCT. And this patient presented with infiltrative pathology in the chest X-ray, CT done, showing the crazy paving appearance with ground glass and thick interlobular septa and lung infiltrations and consolidations also in the other areas and thickening of the fissure. And this was diagnosed as acute interstitial pneumonia. fourth sign is the tree in bud, and the tree in bud is the meaning the terminal airways are filled with secretions, and making the pictures of the tree in bud like this. The most common cause is infection, and the TB coming on the top. In the top of these infections, if we see tree in bud in the film, typical infections like mycoplasma or fungal viral can cause also tree in bud. Aspergillosis also can cause allergic bronchopulmonary aspergillosis can cause this tree in bud. Cystic fibrosis, which is infection-like process, can cause tree in bud appearance associated with bronchiectasis and primary serial dyskinesia. This 35-year-old female patient presented with cough, showing multiple tree in buds are noted here associated with consolidations and cavitary lesions for patient of TB, as we mentioned before in differential diagnosis. The differential diagnosis of pulmonary fibrosis or can be occurs in the upper loop or in the lower loops and have differential diagnosis according to the site of fibrosis. The end stage of pulmonary fibrosis can cause the fifth sign of specific signs in the HRCT, which is called honeycomb. Honeycombing meaning multiple cysts like this with thick wool, and it attaches to the surface of the pleura and arranged in rows like this. The most common cause of fibrosis in the upper loop mnemonic word is the TRAS, referring to TB, extrinsic allergic alveolitis. If there are another exposures to allergens or like this, radiation pneumonitis, if we have sharp lines and clips for thyroid, breast, or axilla, ankylosing spondylitis, if we have bamboo spines, sarcoidosis, if have hilar lymphadenopathy, or silicosis, if there are history of worker. Lower lobes is mnemonic crabs causes of fibrosis. See from cryptogenic organizing fibrosing alveolitis or idiopathic pulmonary fibrosis, which occurring with usual interstitial pneumonia if there are no definite cause for this fibrosis. Rheumatoid arthritis can cause also lower loop fibrosis, and concomitant finding in the film can show arthropathy in the glenohumeral joint or sternoclavicular joint, which you can see in the film. Asbestosis, if there are pleural breaks, bleomycins according to the history, scleroderma if there are dilatation of the esophagus. So the honeycombing appearance is the end stage for the pulmonary fibrosis. According to the concomitant data and concomitant finding on the film, we can reach to the differential diagnosis as we discussed. And this case of honeycombing, which is showing multiple rows of cysts with thick walls arranged in rows and contact to the pleural surface. And this is the honeycombing for usual interstitial pneumonia patient in the end stage for lung fibrosis. It is associated also with bronchiectasis. This is called traction bronchiectasis due to fibrosis and loss of volume. And this is diagnosed as bronchiectasis because it is connecting to the bronchial tree. So what is the summary and conclusions from this presentation? Questionnaire mapping for the HRCT diagnosis. Is there a HRCT specific sign like halo sign, invasive halo signs, atoll signs, crazy behaving, tree in bud, or honeycombing? And reach to the list of differential diagnosis through these specific sign. What is the classification type? Is it reticular, patchy, cystic, or nodular? And take one from these. If we, for example, patchy opacity, look at is this patchy opacity subtypes due to ground glass or due to consolidation, due to mosaic attenuations or air trapping. After that, you should enumerate or memorize short list of differential diagnosis for each sign. And do you have any concomitant data as history of primary or like this, or finding on the film as arthropathy or calcified pleural plaques or like this, smoking history, local predilections, peripheral distributions, primary, you can reach to your diagnosis easily. And this is my reference. Thank you very much and have a nice day.